Hello, my name is Kenyon Hopkins, and I'm a P4 API student at the School of Pharmacy General Hospital. The date is February 16th, 2020, and I would like to first thank you all for coming here today to talk about the inclusion of Repatha, evolocumab, a PSK-9 inhibitor to our formulary for statin-intolerant patients. Before I get into whether or not we should include it and the pros and cons, I think it's important to first understand why we're having this conversation. 10 to 15% of patients experience adverse events while on a statin. This can include myalgia, type 2 diabetes mellitus, and rhabdomyolysis. When looking at these adverse events, it's important to know that a lot of them are caused by the type of statin. So hydrophilic statins, such as rosuvastatin, have a less chance of adverse events compared to other statins that are lipophilic, such as atorvastatin. Along with this, genetic variants in the patients, such as the organic ion transporter SCLOB1B1, which helps statins get into the liver, have higher adverse events. Patients with this genetic variation have found to have a 43% higher chance of experiencing adverse events compared to the general population. Currently on our formulary, we include ezetimibe and fenofibrate in order to treat statin-intolerant patients. A little overview of the PSK-9 inhibitor evolocumab. It is used for hypercholesterolemia and adjunct to diet and exercise. It is a monoclonal antibody, IgG2, which inhibits proprotein convertase substitutillin kexin type 9, or more aptly PSK9. What this enzyme does is it degrades the LDL receptor on hepatocytes. With less LDL receptors, there isn't as much LDL getting into the liver, so there's a higher blood concentration. By inhibiting this enzyme, which degrades that receptor, we can expect higher levels of the receptor on the hepatocyte surface and a decreased level of LDL in the blood. Currently, ezetimibe lowers LDL by 10 to 20% and has the adverse effects of muscle pain, diarrhea, tiredness, aches, and pains. Fenofibrate lowers 10 to 25% and also lowers hypertriglycerides, which, as we know, is a comorbid condition and often accompanies a lot of patients with hypercholesterolemia. The adverse effects of fenofibrate include muscle pain, GI distress, gallstones, and an increased risk of bleeding, which is important when we consider that a lot of patients might be on a blood thinner or have an already increased risk of bleeding. What's nice is that the combo of these two drugs has found to lower LDL by 36%. Evolocumab, on the other hand, reaches its steady state in 12 weeks and a Tmax in 3 to 4 days. It has a half-life of 11 to 17 days and is found to lower LDL by 50 to 75%, which is a lot higher than ezetimibe fenofibrate combo. What's also nice about evolocumab is there is no renal or hepatic dose adjustments, though they found in hepatic issues that there's less drug available, but it didn't really have an effect on the efficacy. There are really no special population considerations when looking at this drug. There hasn't been a lot of studies done in pregnancy and lactation, and of course, like most drugs, in geriatric populations there's a higher risk of adverse events. The adverse events that are associated with this drug more commonly include nasopharyngitis and upper respiratory tract infection. This happens in about 5.7% of patients. And the more serious adverse events are osteoarthritis, which happens in 1.3% of patients, hypersensitivity reactions in 10%, and new onset diabetes in 4%. Little tidbit that's nice about this drug as well is the adherence with this drug is a lot higher compared to statins, 79.4% compared to 30.9% respectively. The number needed to treat with this drug is 21. A big consideration in whether or not we'll add this drug to the formulary is the cost and the benefit that we expect out of it. Currently, ezetimibe costs around $14,350 a year, whereas the PSK9 inhibitors cost $450 a month with insurance, or $5,400 a year, and $1,117.15 without insurance, or $13,405.80 a year. The Institute for Clinical and Economic Review did a study on comparison of these two drugs, and with a quality of life threshold at $100,000 a year, they found that ezetimibe was found to be $145,000 per quality adjusted life year, and $274,000 for evolocumab. The threshold in this analysis was $100,000 a year. However, there was 270% more quality adjusted life years with the PSK-9 inhibitor comparatively to ezetimibe. In that study, they found that the cost effectiveness of this drug would have to be around $9,669 a year. In order for this to happen, the patient would have to be on insurance. Patients without insurance would not get the cost benefit that would be required. Currently in the guidelines, it is recommended to use a statin in hypercholesterolemia, but as we said before, statin intolerance is pretty common. And when looking at what you use to treat it, besides a statin, you would add ezetimibe and possibly fenofibrate, and then the third line option would be a PSK-9 inhibitor, such as evolocumab. With all this taken into consideration, I think that we should include evolocumab in our formulary, but only under very certain conditions. First, the patient has to be deemed statin intolerant on at least 2 different statins. Being able to look at whether or not one statin is better than the other is very important. And a lot of the times it is found that switching a patient on a statin will have better outcomes. And even switching the dosing to like every other day or even twice weekly can also have an effect. In addition, genetic testing for the genetic variant of SCLO1B11 should be done to make sure that there is no other confounding factors on why the patient could be having these adverse events. If the patient is obese or overweight, or of a BMI of 25.5 or greater, they should be sure to get a 10% reduction in their weight and reassess their cholesterol levels so that we can make sure that their weight isn't an issue. In addition, the patient should then be started on ezetimibe and fenofibrate, and if the LDL is still not within goal, that is when we will add evolocumab. I do not believe that evolocumab should be stored at the hospital. There are a lot of pharmacies and areas where we could receive it in a prompt, quick manner, and if there is a delay in getting it, then apheresis could be done in the meantime in order to alleviate some of the stress and burden that is associated with the elevated LDL. If you have any questions regarding anything that I said during this presentation, feel free to send me an email in my contact information on the dossier. Once again, I thank you for listening today, and once again, any questions, feel free to ask. Have a good day.